The next presenter is Dr. Andrew Allegretti. Dr. Allegretti is an associate professor of medicine at Harvard Medical School and a nephrologist at Massachusetts General Hospital, where he is also the director of ICU nephrology. He's an expert in hepatorenal syndrome and has been a lead PI in a number of clinical trials associated with kidney disease in the ICU and hepatorenal disease. And really looking forward to hearing this talk today. Thank you very much, Dr. Allegretti.
Thank you very much. Happy to be here. Thank you to all the listeners and attendees for being with us. That's my intro slide and my disclosure slide. So we'll start with an audience response system. If everyone has that one handy, I'll read it and you all can vote for your favorite. A 62-year-old man with end-stage liver disease due to hepatitis C presents to the emergency room with melena. He takes only propranolol, furosemide, and spironolactone at home. On arrival, he appears well with a blood pressure of 109/50, heart rate 90, scleral icterus, and a mildly distended abdomen. Labs on arrival show a creatinine of 2.5, up from 0.8 3 weeks ago as an outpatient. Urinalysis and renal ultrasound are normal. He is admitted, diuretics are held, and he is given 50 grams of intravenous albumin for 2 days. Repeat labs on hospital day 3 show a stable creatinine of 2.5. What is the cause of his AKI? A, hepatorenal syndrome, B, acute tubular necrosis, C, prerenal AKI due to intravascular volume loss, or D, hepatitis C related renal disease. And I'll give folks a minute to vote. Looks like on my end, we've got votes for A, hepatorenal syndrome, a couple for B, but this is A, hepatorenal syndrome. We will talk about why that is as we go through the talk. So here are the objectives over the next 28 or so minutes. We'll talk about the pathophysiology of hepatorenal syndrome and really all of AKI and cirrhosis, but really emphasize the hepatorenal aspect because that's how we approach the disease clinically. We'll of course go through treatment updates and then look forward to where I think the field is headed. I start almost all my talks on hepatorenal syndrome the same way. First, AKI in general in cirrhosis, especially decompensated cirrhosis, is incredibly common. But hepatorenal syndrome as an entity is technically a rare disease as defined by the FDA, which means there's just 200,000 cases of it in the United States or less per year. But when you're taking care of a population of patients like this, it may feel more common. In the days before vasoconstrictors and intravenous albumin therapy, the untreated mortality for hepatorenal syndrome was cited as high as 90% in the short term, which is quite incredible. But in the more recent era, when we have vasoconstrictors and albumin, the 90-day mortality has been hovering around 50%, which, while improved obviously from the generations past, I would still argue is some of the sickest patients we will see. I mean, if you go to an ICU and look at a patient on CRRT, that's about a 50% chance they make it out of the hospital. So it's really quite incredible. You can see on the right the breakdown of injuries. Most of them are what I would consider hemodynamic or nephrotoxic injuries, your classic prerenal injury and ATN, and then hepatorenal syndrome is a special scenario that you see about 1 in 8 of all serious AKI in the hospital for this population. But it is very difficult to diagnose across that spectrum of those three. There is not a single definitive test that will give you an HRS diagnosis, and the triggers that sometimes can trigger any of these. For example, an infection can cause volume depletion that responds to fluids. It can lead to septic shock, which would be more indicative of ATN, or SBP, spontaneous bacterial peritonitis, is a very common trigger of hepatorenal syndrome. So you can have the same clinical prodrome, the same setup, and have it cause all three of these things. And obviously the management is very different depending on what type of AKI you have. This is an important slide and one I always come back to. Understanding the pathophysiology of hepatorenal syndrome, at least the hemodynamic pathophysiology, and I put in parentheses and ascites because that is the natural antecedent condition, and in fact, in the diagnostic criteria, it's required to have in order to diagnose HRS. But just walk through this with me. You start in the liver. Hepatorenal syndrome is indeed a disease of the liver where you have a highly fibrotic, resistant organ where there's vasodilators and inflammatory mediators that dilate the portal or the splanchnic or the mesenteric system. So all this blood is pooling away from the systemic system, so you have decreased effective circulating arterial volume. And when your body senses that, it has all these mechanisms that are designed to fill the tank back up and vasoconstrict, and that includes upregulation of renin-angiotensin and aldosterone. Vasopressin or antidiuretic hormone, ADH, is released to hold on to free water, and then the sympathetic nervous system is upregulated. This feeds to the kidney, and initially you get sodium and water retention, which is why ascites precedes hepatorenal syndrome, and why usually you'll see these patients are hypervolemic but yet hyponatremic when water reabsorption or water retention exceeds the ability to hold on to sodium. You get hyponatremia. But then when the vasoconstriction gets so severe, it results in this largely functional AKI that we define as hepatorenal syndrome. I always mention that the heart is an important part of the physiology of this population. When I think about these patients who are maybe ambulatory and they have a relatively normal creatinine and they're either getting large volume paracenteses periodically or balanced on their diuretics, that's a high output state. And when we think of cirrhosis as a decompensated cirrhosis specifically as a high cardiac output state, and the inability to mount that cardiac output is a key inflection point when you distinguish between that balanced patient who is still decompensated by the definition of cirrhosis, but maybe is ambulatory, as opposed to the admitted patient or the patient who's suffering an AKI or progressive renal dysfunction. Said another way, every patient with portal hypertension exists somewhere on the spectrum between normal circulation and hepatorenal syndrome, which is a line we draw in the sand to define as a syndrome. I sometimes refer this as to a mixed or a hepatorenal physiology, and if you're more balanced, you may be more ambulatory or outpatient. You are closer to normal circulation, and if you are more decompensated and decompensating, in fact, you may be closer to hepatorenal syndrome, and people can move back and forth, obviously, based on what's going on acutely. So that's the physiology, and of course, when you have a sort of vague or a syndromic phenomenon like HRS, it's important to define it as best you can. And it's important to identify not just for treatment, but also for prognosis. We've known for a long time that patients who have hepatorenal syndrome, and this is a graph on the left of the older terminology, which was type 1 HRS, which we would now call HRS-AKI, and type 2 HRS, which is more like the HRS-CKD that we would call now. Even at the same MELD score, patients with hepatorenal syndrome fall way off and have a way worse survival expected than those with a similar MELD score without hepatorenal syndrome. And in fact, in order to capture this acute morbidity of such acutely decompensating events like HRS, there's this newer scoring system. It's been around for 10 or 15 years in the research literature, but only just made its appearance in clinical medicine for the first time on terlipressin's label, which we'll get back to in a bit. Which is the ACLF, or Acute on Chronic Liver Failure score. It's important to familiarize yourself with it because it is an important part of prescribing terlipressin now. There's basically like a SOFA score for patients in decompensated liver disease where you get points for 6 different organ systems: liver, kidney, brain, coagulation, circulation, and respiratory. And you can see the more organs you have go down, which is farther to the right, and the more points you get, the worse you're going to do. And this captures acute mortality a little bit better, but also is important when we get to the terlipressin slides. The International Club of Ascites has been defining hepatorenal syndrome for the last, say, 2 generations. The most recent large-scale update was in 2015 and has been largely adopted and slightly adapted by different national and international societies. But this is sort of the bones of what we've been working with for many years. And think of it as a checklist, as a group of diagnostic situations or prodromes or, rule outs, if you will, to help you address other forms of AKI and rule out other AKIs in a population at risk. And that population at risk is patients with cirrhosis and ascites. They obviously have to have AKI, so that's a relative change in serum creatinine as it's currently defined by the KDIGO guidelines. And then the most probably controversial one at this point in the game is a 2-day volume challenge, which has historically been defined as withdrawing diuretics for 48 hours, as well as giving a 1 gram per kilogram IV albumin challenge. Albumin given in cirrhosis because in some cirrhotic indications, such as SBP and after paracentesis, it has been shown to have favorable sort of circulatory and renal outcomes, but in this particular population, never been tested, believe it or not. But in any event, that would rule out a pre-renal injury, and HRS doesn't respond to albumin alone typically. And then absence of things that would be more indicative of tubular damage, such as shock or nephrotoxin exposure. This one is the last one that you have to take with a grain of salt, which is signs of structural kidney injury like hematuria or proteinuria. That being said, in today's world, with the increasing metabolic associated liver disease and concurrent obesity and diabetic nephropathy being relatively common in this population, you can certainly have some underlying proteinuria, and if you put a Foley in, some underlying hematuria from traumatic Foley placement. That wouldn't necessarily rule out an acute hepatorenal syndrome. You have to use your clinical judgment there. Get a lot of questions about what to do about the sediment, because these patients often have bile casts or muddy brown casts for a lot of different reasons. So I don't think tubular casts or granular casts on their own rule out hepatorenal syndrome. It's just a piece of data. And then in Europe, the approval and availability of other tubular biomarkers like NGAL is more widespread, but it's not officially in the diagnostic criteria. I find those helpful as well, and I'll get into that in a couple of slides. In 2024, a slight update was put into the guidelines by the Acute Disease Quality Initiative in concert with the International Club of Ascites, which was, I think, largely driven to do two things. One was simplify the diagnostic criteria in the sense that it would empower clinicians to use terlipressin or vasoconstrictors like it more liberally and use it more early in the disease course. And in order to do that, they also wanted to reduce the risk of volume overloading the patients with a mandatory 48-hour volume challenge. So in truth, it's not that different in intent, but it is different in practice, where you still need cirrhosis and ascites, you still need AKI by serum creatinine, but you no longer need a mandatory 48-hour volume challenge. And in fact, went so far as to recommend against it routinely. Give it if it's appropriate clinically based on your volume exam. And then they simplified these last sort of 3 bullet points in the previous into no alternative AKI cause. And while this helps somebody like me who's very comfortable making these diagnoses and sees this all the time, if you're looking for the algorithmic approach, this older criteria may be better because you can check off the boxes and still get to a pretty reasonable answer by the end of it. In 2024, in response to these new guidelines, some of the European centers that have been using and working on the older set of guidelines for a long time released an algorithmic, but albeit retrospective approach to, it says prospective cohort, but this was a non-intervention study where they just sort of applied the older algorithm to consecutive patients, and those patients did pretty well. So I think either way is a reasonable approach to the initial period of AKI diagnosis in this population, depending on what you're comfortable with. Regardless, I think a relative change in serum creatinine is still very important in this population. Even small changes in serum creatinine, a 0.3 milligram per deciliter increase, for example, in defining a stage 1 AKI, still results in worsening survival in this population. And obviously, the more severe AKIs have worse outcomes. There are limitations of cystatin C, of creatinine, of course, some of which we can address by cystatin C. For example, creatinine is a muscle breakdown product. Many of the patients with decompensated cirrhosis are sarcopenic and thus may mask their true kidney dysfunction. And we've done a couple of studies looking at different situations. Cystatin C has performed the best and is best defined in the outpatient setting. So when looking at concurrent creatinine and cystatin C measurements at the time of liver transplant evaluation in patients who are listed, not only does cystatin C seem to correlate a little better with long-term mortality, but just having a delta or a mismatch between creatinine and cystatin C is independently predictive of poor outcomes, which may reflect, in fact, that sarcopenia that is hard to capture otherwise. There are other biomarkers aside from cystatin C that I think are quite helpful, but are not in the diagnostic criteria for AKI and cirrhosis and hepatorenal syndrome. One of them you definitely can send, and that's a fractional excretion of sodium, or a FeNA, or just a urine sodium, if you will. You can see here multiple different studies have looked at the fact that patients with prerenal injury and HRS, both of which are sodium avid and functional injuries, have very low FeNAs, and those with ATN have much higher FeNAs. The challenge is that many labs only have a urine sodium that go down to 20, and that might not be low enough to distinguish between them all. But in any case, I send a FeNA or a urine sodium on every patient I see with AKI and cirrhosis, and I encourage you to do the same because I do think it's a valuable piece of information. NGAL, which I briefly mentioned earlier, a urinary biomarker that's approved in Europe and also has a pediatric label for early detection of AKI in the United States. It's not really widespread used at this point, but if you have it available to you, many sites, including ours, have done research in this space suggesting that a lower NGAL is more reflective of the functional prerenal or hepatorenal injury, and a higher NGAL would be more indicative of ATN in this population. And in fact, this biomarker has performed very well. Not approved yet in adults, but undergoing studies to do so. So please stay tuned. And at some point, you may get it in your hospital if you are have a pediatric center attached. And this would be a potential off-label use of it if you were considering it in this population. Just a brief mention of glomerular disease and cirrhosis, since this is a liver and the kidney talk, not just a hepatorenal talk. Lots of glomerular diseases are associated with liver disease. The most common is probably IgA nephropathy, whether that's specifically related to alcohol-related liver disease or not. I've seen it across all different etiologies of cirrhosis. And the decreasing in prevalence viral-mediated associated glomerular disease like Hep C or Hep B associated. We see these so rarely in the United States, at least because of the low prevalence of these viruses. And I'm just listing them here, but know that hepatic synthesis is responsible for complement, the liver is responsible for complement synthesis. So low complements may not in fact be indicative of glomerular disease, but may just be low synthetic hepatic dysfunction. So if you are sending them, just keep that into your mind. So to summarize the diagnosis of HRS, I do think hepatorenal syndrome remains a diagnosis of exclusion, and I would add that if you have a patient that's hypertensive or has a high urine sodium, it makes it less likely. Again, these aren't perfect tests, but these are situations where you can use additional clinical information to help inform your pretest probability of the injury. I have seen plenty of normotensive and even a little bit borderline hypertensive HRS, but it's not the usual phenomenon. And many of these patients may have more than one thing going on at once. You may not need a volume challenge for every patient, but if they're not overloaded and you have tools to assess that beyond sort of physical exam, which can be very difficult in this population of patients who are always almost extravascularly overloaded, you may think about tailoring your approach in that way. And of course, the earlier you intervene, the better, because the severity or AKI stage correlates quite well with prognosis. So now let's go into treatment updates. I call this section pre-transplant treatment updates because anyone with hepatorenal syndrome or really any serious AKI in cirrhosis really needs to be aimed towards a liver transplant if they are at all a candidate or potentially a candidate. We are providing a piece of supportive care, much like the rest of the liver care that we provide these patients, that in the absence of modulating the underlying liver disease will likely not have a long-term effect on their survival. For example, most of these patients, by the time we meet them here, are quite decompensated and really in need of that if they're going to have more than a few months or years survival ahead of them. The health officers at my institution use this acronym VIBES, VIBES, for volume, infection, bleeding, encephalopathy, and screening/surgery for all the areas of supportive care these patients need. I would add an R to this, so I usually call it VIBERS to add renal, because even if you have normal renal function in this population, it's still an at-risk population, and of course needs to be managed as such. So outside of giving albumin, which is used fairly liberally in this population for a variety of reasons, the vasoconstrictors that I've listed here are, for the most part, the mainstay of treatment of hepatorenal syndrome once you've established the diagnosis. You can see by far terlipressin is the best studied. It's also been shown to be the most effective and generally favorably effective as norepinephrine. But midodrine and octreotide, which I think a lot of people are still using as a force of habit, I guess, or maybe because it's been on formulary but off-label for many years for the floor treatment of hepatorenal syndrome. It's quite cheap and safe, and people have been giving it for a long time, but I've found it not to be effective at reversing hepatorenal syndrome. And in fact, in the one trial, it was compared directly to terlipressin. That trial was actually stopped early because midodrine and octreotide was inferior at reversing hepatorenal syndrome compared to terlipressin. Terlipressin is an analog of vasopressin that has a lysine side chain attached to it, so it is a little bit longer lasting and thus can be given as a bolus. But it does have some serious side effects, which we'll go over, and thus should be used with a little more scrutiny than midodrine and octreotide. The 2021 confirmed trial was the largest and most important terlipressin study, which compared terlipressin plus albumin versus albumin alone for the treatment of hepatorenal syndrome, and it met its primary endpoint, which ultimately led to the approval of terlipressin, which I'll get into in a bit. But even with a lot of caveats, sick population, heterogeneous presentations, it still sort of has a nearly double of an effect of improving hepatorenal syndrome compared to placebo. And the earlier you use it, and this is actually true of any vasoconstrictor or of any therapy, the earlier you use it, the more likely it is to be effective, which is why we tend to not want to delay by using midodrine and octreotide for a few days, watching the patient get worse, and then trying the therapy. In fact, once you get to a creatinine of above 5, it's really poorly effective. In fact, there's a label to consider not using it because it's unlikely to be effective in that group. Any drug that doesn't modulate the mortality of a disease, and again, this is not a drug that improve survival on its own in any particular trial needs to be looked at very carefully in the setting of its adverse events. The most common adverse event that I see is probably abdominal pain, and it's sort of an on-target effect. It is a vasoconstrictor that is designed to constrict the splanchnic circulation and push blood into the systemic circulation via the V1A receptor, just like vasopressin would. And so abdominal pain, cramping, diarrhea, nausea, very common, and is usually dose limiting or dose responsive. So you can often get around that with either lowering the dose, or in Europe they use a continuous low dose infusion rather than bolus dosing. But the most important side effect, I think, to be aware of, and arguably one of the most deadly, is respiratory failure, which was quite a signal seen in the CONFIRM trial, with a much higher rate of terlipressin in the terlipressin arm compared to placebo. This led to a boxed warning to be cautious around patients at high risk of respiratory failure. And in a subsequent post hoc analysis, it was identified patients with ACLF grade 3, which was that scoring system we talked about earlier, are bearing the brunt of the respiratory failure events. And these were quite real respiratory failures, many of which led to death or intubation. In reality, I think it's kind of hard to do this unless you set out in your template to calculate an ACLF grade. Because when you think about grade 3, that means 3 organ systems are down. And usually, not always, but usually you've met the bar for liver and kidney failure just off the bat because of your labs and the patient population you're dealing with. So that just means you have one other organ down. Could be severe encephalopathy, could of course be underlying respiratory compromise on top of that. Makes it not only less effective that you're going to respond to terlipressin, but more dangerous. And in fact, it's recommended against doing that based on the warning label. And of course, if you're already on oxygen, that's another reason not to use terlipressin, and you should be monitoring continuous oxygen saturations in this population to begin with. I have found that if you're cognizant of this and you notice, it's generally pulmonary edema that forms, and the theory is you're giving albumin to these patients, which increases preload. You're giving terlipressin, which if it's acting in the V1A receptors in the gut circulation, that's also giving preload by pushing blood into the vena cava. But terlipressin is an analog of vasopressin, so it's also an afterload increasing agent. So you're giving preload, you're increasing afterload, and in someone who's at risk for pulmonary edema, you're not really doing anything to the heart. It's not like it's a beta adrenergic agent like norepinephrine would be. And so you have an increased risk in a, say, patient who's infected or inflamed in ACLF grade 3, or primed with pre-existing cardiac disease, and you can wind up with pulmonary edema that way. But if you stop the drug and diurese, I've caught this before and then just diurese these patients, and they tend to do okay, but I think you got to be aware of it and intervening early. Terlipressin is generally dosed in bolus because that's how it was studied in the trial that was led to its FDA approval, where you would assess its efficacy after 3 days and either continue the drug, stop the drug for no efficacy, or increase the dose if it's sort of a little bit efficacious but not quite getting you there. More recently, I've been advocating to get more people to use continuous terlipressin because, number one, even though it's off-label, you can use less drug per day, so it's the equivalent of 2 bolus doses spread out over the course of a continuous infusion over 24 hours, and it has a lower side effect profile with similar efficacy. And this is how they use it in Europe. Again, off-label currently, but I think well-studied enough that I feel comfortable using it, and tends to be better tolerated. We studied the post-approval use of terlipressin in a large multi-center cohort of so-called real-world terlipressin use against the sort of compared to the CONFIRM trial, which was a clinical trial setting. You can see our population had pretty remarkable reversal and side effect rates compared to the CONFIRM trial, which I think to me is reassuring in the sense that it did what we were expecting it to. And I can say in my clinical experience, it certainly doesn't cure everyone, but in the carefully selected patient, it does improve kidney function in a variety of different scenarios. I don't use it nearly as liberally as you might have, as I implied earlier, as midodrine and octreotide, but I do use it as a first-line agent in patients I think are likely to benefit from it, and we're trying to improve kidney function as we're waiting for either liver transplant or not in the case of trying to avoid dialysis. Dialysis is a really big deal, of course, in patients with liver disease. In general, you can break them down into 3 buckets, and based on their transplant listing status, they're either already listed, they're not listed, but maybe a candidate, or there's a clear contraindication to transplant. The first group is easy. We typically start renal replacement therapy as a bridge to transplant. The second group tends to be straightforward up front, where you're expediting a transplant workup, and then hopefully they'll get shunted over to the good side. But many patients either come in with a contraindication or are unable to complete a transplant workup, and then you're left with a contraindication to transplant, and thus a decision to make about whether you should pursue, continue, or initiate renal replacement therapy in this population. And this may be some of the questions you may ask yourself. Is there reversibility? Do they have HRS or ATN? Does that even matter? Will there be a future change in their candidacy? And this is a rapidly evolving area, because I think nationally protocols about presenting with alcoholic hepatitis and sobriety counseling has changed pretty dramatically over the last 5 years in a more liberal way, meaning we are certainly in Boston transplanting more patients without the historical 6 months of sobriety counseling that has sometimes been required. Will they tolerate HD? Will they make it out of the hospital, or will they wind up in the ICU on continuous renal replacement therapy? It doesn't really matter what their etiology of AKI is. If you're not listed for transplant at 6 months, you have a very low chance of being alive, and certainly alive and off dialysis is quite rare. If you are listed for transplant, about 50% of these patients, at least in our experience, have gone on to get transplants, which is great. But if you don't have that as an option, or you're unable to get a transplant, the chances that you're alive and off dialysis are very low. So in that setting, and it's actually in the liver guidelines, and I think increasingly used, palliative care consultation and symptom-driven management, as opposed to more invasive measures, have been increasingly employed. I think it's appropriate to focus on comfort or end-of-life care in a lot of these cases for those who don't have transplant as an option, but certainly not at all. And I'm not someone who doesn't offer renal replacement therapy if transplant is not an option. I will employ a time-limited trial, a very open and honest discussion before we were to start. But some patients, their goal is not to, recover and live long. Sometimes they need some time to get their affairs in order. Sometimes they're just not ready. I think this is important context to consider, and I could give a whole other talk on this kind of discussion and how to have it, but out of the scope, I think, of what we have time for today. Certainly something that I think troubles a lot of nephrologists, and I think it's hard to make a set of rules for everyone. I don't want to end on a bad note, though. There are lots of good things that come out of this. Like, I get to follow many of these patients after their transplants, and they end up out of the hospital and looking well. One of the other challenges in this group is whether or not you provide a simultaneous liver and kidney transplant. Transplants are, of course, a limited resource. Liver transplants do much better, as any surgery does, with better postoperative kidney function, and you can sort of semi-guarantee that by giving a simultaneous transplant. But then that takes away from our ESRD pool. In 2017, the guidelines changed, and it made it pretty objective how to assign these organs. The biggest rule is that if you have CKD as defined as having a GFR under 60 for 90 days and a GFR under 30 at the time of liver transplant listing, then you will qualify for a combined transplant. Doesn't say how you have to measure this, so you have freedom to use a cystatin C formula, a creatinine formula, a creatinine clearance formula, a iohexate clearance if you want, iothalamate clearance if you want. But in reality, this is the only functional way I see a lot of patients getting their dual organs, because the second way, sustained AKI, meaning you have to be on dialysis for 6 weeks, it's really hard to be alive that long and not get the transplant. So in reality, I don't see a lot of that. There's a couple of metabolic diseases that you'll see on a board exam, but probably not in practice, that also warrant a dual organ. This has led to, I would say, a stabilization in the SLK rate and an increase in the kidney after liver transplant rate, which these patients in the first year after transplant are entitled to a safety net evaluation, meaning they get liver transplant or kidney transplant priority listing if they don't recover their kidney function and they didn't get the dual organ. So my take-home messages: AKI in cirrhosis has high mortality regardless of cause. The diagnostic criteria for HRS are meant to guide your clinical suspicion, though this is a difficult diagnosis with overlap between the two main persistent etiologies of HRS and ATN. We think of HRS as a hemodynamic insult, and when appropriate, you should be using terlipressin as your first-line agent, but with careful assessment and iterative evaluation of these patients.